The American College of Cardiology and MedAxiom are transforming cardiovascular care together. Welcome to MedAxiom HeartTalk, the podcast where cardiovascular thought leaders come together for one ultimate goal: to continually transform cardiovascular care for all. MedAxiom HeartTalk starts now.
A significant opportunity and initiative in most programs is the way they handle outreach. And I'm really excited today to be joined by Dr. Recchia from Traverse Heart Vascular, as well as Stewart-Huey from the Children's Healthcare of Atlanta Cardiology service line, as well as Dr. Vincent from Sibley Heart Center Cardiology, to talk about the way they have approached their outreach and the benefits that they see, as well as any challenges that they have come through over the years. So we'll start with Dr. Recchia with you. If you can kind of describe a little bit about your footprint as well as the way you've approached your outreach management and programming.
Yeah, so our footprint is, Michigan's a little bit of a funny state, right? There's about 10 million people in the state. 8 million of them live in the palm of the mitten, and about 2 million of them live in the rest of the state. We're located in the fingers of the mitten. So we have a large geographic footprint that we have to cover with a relatively low population density. So outreach is critically important to us being able to deliver the care. The other issue for us is because we're adult cardiologists, a lot of our patients, the majority of them are in the Medicare age group. We live in a part of the country where it snows for part of the year, so travel, especially for patients in that age group, is a gigantic issue for them. So outreach is really for our patients and has helped us to try to keep as much of the care local as we possibly can for all those reasons.
Now, one of the things as I was talking with your program was a description around significant growth coming out of your outreach areas. So can you tell us a little bit about the impact to the hospital system and the opportunity that you have found in those areas and bringing, managing the care in those areas, but how that has also grown the program in your kind of hub and spoke model?
Yeah, so the way we've grown the program is really just being present locally to do the initial visits. Then we bring the patients for their invasive procedures if they need them to the main hub. And then we try to always do the follow-up visits locally if at all possible. Right? That works the best for the patients. That's what they like. We do some local diagnostic testing. It can get a little tricky because sometimes it doesn't make sense to do everything everywhere. Right? So you have to choose what makes the most sense to do in those localities. But that's the way we've done it. As much of the care locally as possible, only having the patient travel for the things that they absolutely have to travel for. And that's been, for us, highly, highly successful on the patient side. Whether it's successful on the cardiologist side, we can have that discussion at a different time because obviously no one likes to do the traveling, right? That's the hard part.
Yep. Oh, fabulous. And then Kay and Dr. Vincent, you have a very large pediatric program with a very significant footprint. Tell us a little bit about your, again, outreach and the strategies that you put into place to partner with those local communities.
Well, Atlanta is in the northwest section of Georgia, but we cover virtually most of the state. There are only 2 pediatric cath labs in the state, and there's 2 pediatric surgical programs in the state. Of that, we do about 85% of the cath and surgical volume at Children's Healthcare of Atlanta. We do significant outreach for several reasons. One is to see the patients where they live for original diagnosis. Inpatient care is usually done at Children's Healthcare, but follow-up care, they go back to their community. And we have offices in 5 cities other than Atlanta, and we do extensive outreach from those offices as well. So it's to bring the abilities of the cardiology care to the patients rather than the patients having to come to us all the time. And Georgia's a pretty big state. To get from the southern border up to Atlanta, it's a 3.5 hour drive. And coming from a small area in rural Georgia, people really don't like the big city and driving in the big city. So we try to keep them away from us as much as possible.
Excellent. And then Kay, from the hospital side, you've got some interesting programs for post-procedure type patients related to surveillance and support to allow them to get back to their communities. Can you describe a little bit of that?
Right. So we have the pulmonary hypertension program and the single ventricle program. Those are two examples of some of our more complex congenital heart disease patients. And so we partner with the pediatric cardiologists through Sibley Heart Center Cardiology and some of the other independent pediatric cardiologists throughout the state of Georgia to follow those patients. We utilize APPs as the coordinators of those programs, and the patients have a lot of contact communication with them. They're able to follow them in a consistent manner. That also allows us to apply the types of protocols that we consider important for these patients and to more closely monitor what needs to be done as far as making sure that they're getting into the outpatient clinics or coming to the hospital as needed.
Great. And you mentioned APPs. Dr. Recchia, I know with your program the APPs have been a significant portion of the way you've delivered the care. Can you describe that?
So we're probably similar to a lot of MedAxiom practices. So originally, if you rewind the clock 25 years, our APP program was an inpatient-only program, and they were just there to extend the physicians, right? So 2 cardiologists could round on a large number of patients because we had a cadre of APPs that were running around doing the initial getting all the information so we could come in and they really function almost like fellows in fellowship training. We ventured into trying them in the ambulatory setting probably around 2010 or so. That was a colossal failure, and that was because our inpatient APPs chose to be inpatient APPs for a reason. They didn't want to do ambulatory care. They were very comfortable in the hospital where if someone was sick, they had us right there, or they could get an EKG or a chest X-ray or whatever immediately. Ambulatory cardiology is much different than that. That was a failure. We backed off of that, and then we sort of regrouped, and around 2015 we decided to have a specific outpatient ambulatory APP model. So we have 2 separate groups of APPs, and we took the time to train our ambulatory APPs in how to be ambulatory cardiology APPs. And that's made just a gigantic difference. The ones who chose to do ambulatory APP work, they chose it for a reason. That's what they wanted to do. And so they're getting good at it. The program you've put together, the APP training program is a must for our people now. And it's slowly grown. Probably the biggest challenge we've had is trying to get cardiologists to understand your patients are willing to see an APP. You don't think they are. You think you're the only one that they want to see. But the fact of the matter is it's not true. And so that's been our biggest challenge now, is looking at trying to get everybody on board to say, look, you don't need to see a stable coronary patient yourself every year. You can see them every other year, and an APP can see them on the off years. And so we're slowly moving the needle in that direction.
Now, have you been able to pull any physician time back for other areas to utilize by utilizing APPs in those outreach areas, or is it just more of you've been able to expand your presence?
So we had a big issue, like I'm sure a lot of practices did, with very long lists of recall, right? Patients who needed to see me in March of next year, who there was no way they were going to see me in March of next year. The APPs have helped us solve that problem. They've really helped us solve that problem in outreach. That's been very helpful. One of the slippery slopes we can get into in outreach is if an APP is in outreach alone. It's one thing if they're in our main hub, they've got cardiologists 5 feet away that can help them. But if we send them to an outreach market on a day that I'm not there, it's not ideal. And they've been very vocal about that, saying it's really not our favorite way to do it.
Okay, that's helpful to know. And then Kay,
and I was just going to say, at Children's Healthcare of Atlanta, the way we have predominantly utilized the APPs has been more on the inpatient hospital-based. we have them in our specialty programs, but we've been working with the pediatricians in the community, trying to get them more accustomed to having the APPs function on the outpatient clinics to see certain types of populations of our CHD patients. But that seems to be progressing from where we were, say, 5 years ago.
Okay. Now, have any of you or in either program been able to quantify in any way the value that you're bringing to those outreach, or how do you know that that particular area has been successful in the way that you've staffed it or the way the patients are coming into the system from those areas?
Well, I'll just give you a simple math, right? So last year in our practice, there were 14,000 APP visits. Those are 14,000 visits that would have never been done without them. Impossible. There's no way the rest of us could have done those visits. So for us, it's simple math. Have our recall lists gone to zero? No, they haven't gone to zero. Part of that is probably because of, as I said earlier, this uptake by, I can't force my partners to use APPs. Most of them do, but if you run the numbers specific per doctor, there's a wide variation. Some is very low, 10% of their follow-up visits are set up with an APP. Some are very high, 70%, 80% of the next visit is set up with an APP.
Excellent. All right. Well, thank you. I appreciate your insights. They're very valuable, and we appreciate having you here.
You're welcome.
Thank you.
You've been listening to MedAxiom Heart Talk, the podcast where cardiovascular thought leaders come together to transform cardiovascular care for all. Follow MedAxiom, an ACC company, on LinkedIn, Twitter, Facebook, and YouTube. If you haven't yet, please subscribe, rate, and review this podcast. Join us next week for another MedAxiom Heart Talk episode, and thanks for listening.